colleagues from all over the Middle East and North Africa. It's a big pleasure for me and for my colleagues to start talking about one of the most challenging diseases, diabetes, and mainly focusing on diabetic foot salvage. Our mission is to save feet and save lives and avoid preventable amputations. This is the DFoot mission, and we are all here working hand in hand as a team from all the countries in the world to achieve this noble aim and target. So tonight, we will be talking mainly about different aspects of quality improvement. And we will start our MENA region webinar by the word and the message of our president, Dr. Abbas. He will be addressing the audience with a short video, and we are ready to welcome Dr. Abbas and to watch his video.
It is an honor and privilege to address you today as President of DFoot International. I speak not only to the diverse and vibrant individuals present here today, but also to hearts and minds of millions worldwide, united by a common cause to combat diabetes-related food complications. DFoot International is an organization consists of people working in the field of diabetes-related food complications. These people are spread across 7 regions in the world: Sub-Saharan Africa, South and Central America, Middle East and North Africa, North America and Caribbean, Europe, Southeast Asia, and Western Pacific, all dedicated to providing preventive food care for people with diabetes through awareness, education, and professional guidance. The looming global diabetes epidemic is a step reality, projected to rise with the highest burden in low middle income countries. As diabetes rates surge, so does the incidence of diabetes related complications, including food related complications, which is our focus of action here at DFoot International. Our mission of DFoot International is resolved and clear, ending avoidable low-limb amputation due to diabetes worldwide. It is not just a vision, but a mandate, a call to action, demanding our utmost attention and urgency. We should all unify our goal and aim for a 50% reduction in limb amputation rates by 2026. In this mighty ambition, education and the empowerment of healthcare profession are our only weapons of choice. As I often say and will continue to say, education is only powerful tool we have. Education is power, especially in the low-middle income countries, where it is free and immensely effective when properly implemented. It is noble pursuit. We at DFoot International are proud to see the happenings of Diabetic Awareness Week campaign. This campaign, we find each one of you as a faithful ally in this great endeavor. The success of DFoot International goals depends on your patience and efforts for educating communities and obviously raising awareness. Diabetes Awareness Week campaign is one of the flagship programs of DFoot International. As every year, this year we'll have programs in all the regions starting from 7 to 14 November. We have one day allocated for global meet where all the regions come together on one platform. Today, I invite every one of you to picture a world where every healthcare professional is prepared to offer knowledge and skills to provide specialized food care. Imagine a nation where stigma attached to preventable amputation is eliminated and a gap between affordable and accessible diabetes food treatment is permanently addressed. Coming closer to the end of my short introduction, DFoot International extends a hand of collaboration to every one of you. Let us work together to promote care of diabetes-related food complications and their management, making it financially feasible and increase awareness about it. Lastly, I would like to personally thank everyone present here today for being part of this noble cause. We look forward to the impact we can create together. Thank you so much. Thank you.
Well, after this very nice introduction about the activities of the Diabetes Week, we will start immediately by our first presentation. The theme of our webinar in the MENA region is about quality improvement. And the first lecture will be coming from Sudan, from Professor Muhammad Makki, who will be talking about quality improvement in surgical techniques. Please, Mr. Ali, if Dr. Makki is not ready, can you pass the video?
Well, my name is Muhammad Al-Makki Ahmed, also known as Rashid Ahmed Abdullah. I'm a professor of surgery in the University of Khartoum, Sudan, and as well a director of the Diabetic Center in Khartoum. This presentation is being actually recorded in Atbara city, which is 6 hours drive from Khartoum, northeast. And because of the weak internet services, this is being recorded. The title of my talk is Quality Improvement in Surgical Techniques for the Management of the Diabetic Foot. This is a diabetic center now in Atbara, where this presentation is being recorded. As you see, it's very crowded. We see around 30 to 40 patients of diabetic every day. Most of these patients are neuropathic. Those with advanced ischemia has to be referred to Madani 18 hours from here because we don't have this service here. Well, this is an outpatient, actually, cubicles. Patients are not really charged probably $1 or $2. As you can see here, the couch, and you have the light, and you have got the tray with all the surgical instruments, including artery, forceps, and local anesthesia. Well, I'm showing this slide because the two main causes, actually, of the diabetic foot are the blister because of the hot weather here. And most of these patients, when they have these blisters, probably in the sole or in the toes, they prick it with a needle or aspirate it with a syringe, and that is really causing problems because producing infection. And they have this dressing at home, probably somebody from local healers, and at the end of the day, they come to us in 2 weeks' time or so with bad foot sepsis. As you say, I mean, this patient can easily be managed just by excision and dressing, and within 1 or 2 weeks it will be healed. This is another case. Actually, they present early, and I think this is probably as a result of the health education we have been doing for the last few months, that please come early. Time is tissues as standard. This is a patient who had actually the pharma, and he was walking, and then his slippers went off, and he had this major burn. But he reported on the same day, and this is why actually in 3 weeks' time he had a very healed, nice surgery. Well, I'm showing this slide showing these thorns and nails and needles, very common actually, cause of injury. The problem with this, they implant the bacteria deep in the foot. Patients are not really aware of the seriousness because they just ignore it, and in 1 or 2 weeks, the whole foot is being swollen, patient is feverish, and the limb is swollen. And they report it to us. I think there are 3 main signs, very important. Expose the 2 legs, and you will find it. 1 leg is swollen, warm, and tender. I think if you find this, then there is absolute that the foot downstairs has got a problem. As you can see, similar case is right foot, right leg is very swollen here, the same thing. Well, if you go to the foot down, you might find just a small opening of the injury, whether a nail or whatever it is, and just squeezing. Probably might give local anesthesia if the patient is feeling pain, but most of these patients are neuropathic. So if pus oozes, then you have the entrance. So introduce your artery forceps as far as it goes. Definitely, I mean, the patient has to have a local anesthesia. And as you can see here, yes, this is the right side being very swollen and tender, local anesthesia being applied, and then an incision is made. Please, not an incision, actually, an excision. You have to excise actually along the line, at least, I mean, half a centimeter, 1 centimeter tissues. All tracks has to be open. As you can see, I'm putting an artery forceps And as you see here also, and at the end of the day, I mean, this is a picture you end with where you have got probably well drainage. Most of these patients has to be put on IV antibiotics. Definitely the tissues has to be taken for microbiological culture and sensitivity, and in 3 days they will be started on oral antibiotics. Another important actually aspect is that this foot sepsis, in many times you find it extending to the leg. I mean, what I have shown you earlier as a tender swelling, sometimes it has got a cystic. And you can see here, I mean, the artery force being introduced after definitely is giving local anesthetic, and my finger here feeling this boggy is swelling. So artery forceps, open, drain, and this is the necrotic tissue, especially the tendon, has to be taken and excised. I think you have to be very careful about this. This is just a cellulitis, doesn't need or something probably more serious. Stitches, I mean, long. There can be stitch later with very good results, and you are here. Yes, all these patients has got long wounds that has been. This is important because we have got a dorsum abscess or a dorsum cellulitis. Be careful, because in young patients this might cause digital vasculitis of the arteries and compartment syndrome and ends with gangrene of the toe. And so look at this patient. It's just because it hasn't been drained at the right time. And here, this is the toe. Please don't amputate the toe because of osteomyelitis, since the outside, I mean, the tissues are normal. So the bone has been excised here and it has been stitched back. So there is no indication actually to amputate in a young patient who has got good circulation, who has got an osteomyelitis. Osteomyelitis can be treated now with antibiotics long term, but you have to take a culture from the bone or from the tissues, and the patient has to go into this probably up to 6 weeks. So a combination of antibiotics plus 16 of them is quite adequate. And this is also a picture showing here, as you see, the hallux, the terminal phalanx of the hallux has been completely eaten away. But I mean, no problem, because this bone has been just removed, as you can see here, and the bone has been sent for cultural sensitivity. And this is a clean one which is going to be stitched in the next few days. And thank you.
We all thank Professor Makki for his recorded lecture. And now I will be talking about quality improvement in the practice of a diabetic foot surgeon. So I will be talking about the quality improvement in the practice of diabetic foot surgeons. Quality improvement, is it a plus or a real necessity? I'm stating here David Schwartz in one of the nice books that he wrote, The Magic of Thinking Big. What David Schwartz states in his book, nothing in this world is being done as perfectly as should be. Say I can do better, and ways to do better will appear. Just thinking I can do better switches on your creative power. And personally, my dream as a diabetic foot surgeon is to never stop improving. What about the definition of quality improvement? I will start with one definition that I liked coming from Joseph Brent Hospital in Canada. What he says about quality improvement, most importantly, this is an ongoing process that helps us continuously find new and better ways of doing things so we can enhance care for patients, increase satisfaction, and achieve even better clinical outcomes. What about the CDC definition of quality improvement? The CDC talks about the focus. Quality improvement focuses on, quote unquote, activities. These activities to improve population health, ensures healthcare affordability, and deliver the best patient experience. How to start quality improvement in my practice as a diabetic foot surgeon? Well, a reasonable place to start assessing my own microsystem as a surgeon is the 5 P's framework. The first one is purpose. what is the purpose of starting a quality improvement plan? Overcoming a problem or simply improving my standards of care? 2 patients, define the subpopulation, diabetic and smoker or diabetic and renal failure, etc. 3 professionals, who are the professionals that will be involved inside this program? What are the specialties? What are the processes? Old existing processes that will be made faster and more efficient, or finding new processes, new tools, new devices, new dressing, and introducing them inside the armamentarium of diabetic food management. And last but not least, the patterns. The pattern should be towards humanizing healthcare. And I insist on this word, humanizing healthcare. Reducing errors, increasing staff communication, and implementing evidence-based practice, not any practice. The best quality improvement tool in the microsystem of a sole unique surgeon or a physician is what they call the PDSA, P for plan. We have to plan, for example, to solve a problem or plan to improve the practice. But first, we should recognize our own problem, or we should recognize what is our aim or goal behind quality improvement. The second is do, real-life clinical application of the plan, then study, assess the change in outcomes. How was it before and how was it after? And according to this comparison, act. So we decide either to keep the change or to drop the change. The past 4 slides are the summary of what I learned personally about quality improvement while preparing this talk. The coming slides are the fruit of my 25 years in clinical practice, saving limbs and saving lives. Doing my best to offer my diabetic foot patients not less than the best, to the best of my knowledge, without forgetting at any moment that my best knowledge must always be updated, and that my best standards of care will not remain the best if not constantly improved. While preparing this talk, I was happy to discover that I did intuitively during the 25 years by trial and errors, and this is now more elaborated and has got a skeleton called quality improvement. So let's go together to my wound clinics, to my attempts at intuitive quality improvement. Greetings from my wound clinics. They both look like a hospital ER sometimes. How can I start applying the principle of quality improvement in the microsystem of my wound clinics? Everything starts by defining the problem or defining the aim and what is the desired improvement. Defining the problem, for example, bacterial spread among 5 patients. Once I noticed that 5 patients turned their exudate into a green one suggestive of Pseudomonas infection. The action that I undertook was to take new cultures from all the wound clinic patients, not only the 5. The result was the 5 had Pseudomonas with the same antibiogram, and this is what I didn't like. All the others had other bugs, colonizers, for example. The action that I took, immediate hospital-grade airborne disinfection for all my wound clinic. Then I introduced this airborne disinfection. I added it to the routine surface disinfection of my clinic. I upgraded the waiting room chairs disinfection to quaternary ammonium. I moved the 5 patients to the last 5 appointments of the day. I added Dakin solution to the normal saline protocol for these 5 patients. I added oral antibiotics, namely ciprofloxacin, according to the antibiogram result, and the final result was full control of the spread, and this incident never happened again. Assessing my microsystem as a root cause analysis. Once I had gram-positive bacilli detected in 3 patients in the same week. Action, nose cultures from me and my clinical staff, cultures from the surfaces, from the saline irrigation system, from the antiseptic solution bottles available on the carriages in the clinic. Then throwing all of these bottles and buying new ones, same for normal saline systems. Assessment result, gram-positive bacillus was found on one antiseptic bottle, small, that was filled by a nurse from a bigger antiseptic container. Action, no more large size antiseptic containers, no more manual filling from large to small containers. All small size antiseptic bottles were thrown out once empty, and no more refill habits in my wound clinics. Result, no more gram-positive bacilli in new cultures from patients, neither from antiseptic bottles. Defining another problem that we frequently face, which is slower healing in some cases, or what we call hard to heal wounds. Defining what is my aim? My aim is to accelerate healing using new tools. And this is what we allude at as a switch principle. Switch means speed wound improvement till complete healing. Assessing the cause of this slow healing, cultures, tissue cultures, not swabs, wound imaging, using or buying a new device, for example, Silhouette or Moleculite or other brands. Sometimes we need pulse electromagnetic field device. We can add it or buy it. Buying a PRP centrifuge in some cases and having it ready to use. Adding negative pressure wound therapy when indicating without worrying about the cost. And a more liberal serial debridement to transform chronic wounds into acute wounds. The result will be, of course, much faster healing, holding records in Lebanon with a very low major and minor amputation rates. This is the Moleculite device. The Moleculite locates the bacteria in the wound bed and in the peri-wound, and it helps measuring the wound surface area. This is a pulsed electromagnetic field and microcurrent stimulation. It has mainly two aims, analgesic effect and to perform vasodilatation at a microcirculatory level whenever revascularization is not feasible. Other advanced healing modality is the famous platelet-rich plasma known as PRP. This is one example, one case. Patient presented with a tibial ulceration very close to the bone that was resistant to treatment by other colleagues. He shopped other colleagues and came after 2 months with a bigger wound. And this is where I started PRP. And after 1 month of PRP, you can note the complete healing and the nice skin quality that was regenerated. So this is about platelet-rich plasma. Negative pressure wound therapy, you all know better than me that it is the best treatment for cavitary wounds and areas of tissue loss. It has many clinical advantages and of course has to be manipulated by an expert because of technical issues. These technical issues will allow the machine to perform better or to perform less. This is a case of necrotizing fasciitis. Immediately post-op, the second picture, and then after negative pressure wound therapy, the wound bed was ready for skin grafting. I performed autologous skin graft, and this is the final result. The other case, the foot was a bag of pus after 2 surgeries by a colleague who decided to amputate, but the patient refused. But look at the pus all around on the underpad. Is this foot salvageable with the drain, the many wounds in the foot? I did a salvage surgery, and this is the second picture is 1 week after surgery. Then I started negative pressure wound therapy with an excellent granulation tissue. I did the closure using 2 steps grafting, first with a xenograft and artificial graft, Integra namely, and then with a split thickness skin graft. And you can see the before and after. And this is a frank message for the ending of amputation era. Another tool is total contact cast for plantar ulcers. This is the state of the art for plantar non-healing ulcers. since it redistributes pressure over every centimeter of the plantar surface. And here you can see in pictures how happy, how smiling the patients were, and even the family members of the patient when their refractory plantar ulcers healed in no time. So to sum up, in hard-to-heal wounds, add advanced healing modalities, PRP, negative pressure, PEMF, hyperbaric oxygen that will be dealt with Dr. Salma from Kuwait, carbotherapy, CO2 bath, artificial skin graft, Integra skin grafts, and flaps. Let's come back to the thread of defining the problem. Sometimes the problem is poor compliance with wound care visits, or the patients that who will be lost to follow-up, or long interval follow-up. The cause is mainly poor financial status and sometimes poor intellectual status. The actions that I undertake, I go down on my wound care fees down to $0.6, and this is the lowest, average $3.2 per dressing. I sometimes use low-cost offloading material and wound care material. In rare cases, I go totally free of charge. Sometimes I seek grants for individual cases, mainly to supply them not only to pay for the wound care sessions, but also to supplement them with their medication. I give drug samples to poor patients from my clinic or from grants, and the result is better affordability, better compliance. We'll come back to addressing on a Q other day basis in my clinic if indicated, and again, the very low minor and major amputation rate. Another problem is depression. Patients get depressed, diabetics, loss of motivation, low mood. Why? The cause is fear of amputation and also fear of expenses, anxiety about chances of successful outcome, negative vibes stories among diabetic patients. The action that I undertake in my clinic is serial wound pics using the patient's own mobile so that he or she will see with their own eyes on their mobile how quick is the improvement. I try to involve patient's family, accompanying person to witness the improvement, serial wound measurements, keeping the last one for comparison with the patient, SSRIs if indicated, joyful music and songs in the clinic, distributing roses to patients on Valentine's Day, Father's Day, Mother's Day, and Diabetes Day, and most importantly, celebrating success and complete healing of any patient in a nice and festive way with all the in-clinic patients. What are the results? Much better mood and more compliance. And I frequently hear the patient asking me, tell me, doctor, my turn to celebrate is coming soon. And I will share with you pictures of these celebrations. These are pictures of the Father's Day in June, a few months ago. You can see, look into the eyes of the patient, how bright and shining they are. And here, celebrating success with pictures, likes, and real smiles. Celebrating total healing, and I call it a graduation ceremony because the patient will not need to come to the wound clinic anymore. Personally, I blow with a horn, my nurse will hit with the drums, and the patient in the waiting room will all of them stand up and applaud, if they can stand up, and applaud the healing graduating patients. Here you can see my secretary, myself, and the patient standing up and applauding the graduating. What are my take-home messages? We all have a very important role to play in the quality improvement of diabetic foot management. Quality improvement is about actions and activities, and these actions and activities have to be first safe. Priority is to avoid harming any patient. Second, timely, and we all know that time is tissues, delay equal loss and amputations. Effective, our activities and action should be based on evidence. Efficient, avoiding waste and optimizing and preserving resources, making good use of our resources. And last quality is equitable. Health should be for all people, although it's not easily applicable in its very fine details. Saving limbs and saving lives is my lifetime commitment. Thank you for your attention. Dr. Mariam, would you like to introduce the third speaker? It seems that Dr. Mariam is not there. So our third speaker is Dr. Zahid Mian from Pakistan. He will be talking about quality improvement in non-surgical specialties. Dr. Zahid, the floor is yours.
Thank you. Thank you. Okay, thank you. Thank you, Jamil. Can you see this?
Yes, yes.
Okay. Thank you very much,
Dr.
Jamil.
Zahid, the floor is yours.
Thank you. Thank you very much, Jamil, and everyone for contributing on this deep foot MENA region week for diabetic foot. And I will be discussing about the physician, non-surgical physician dealing with the diabetic foot, the quality improvement. And this is one of the document which every 4 years IWGDF produces. And this is one of the document which is actually is the evidence-based document. And we try to implement this document in our country, or we try to have implementation in every region, so that the quality can be improved in respect to the diabetic foot care. And according to this document, the examination and the assessment of the ulcer should be done by a trained healthcare professional.
Nothing is seen.
And my dear, and my dear friend, colleague,
Your presentation is not seen on our screen.
Yes, yes, we are seeing Dr. Tarazi. Now it's gaps, correct, Zahid?
Yeah, gaps.
Yes.
Yeah.
Okay, you can continue, Dr. Zahid.
Okay. So, but my dear friends and colleagues, there are many gaps in the knowledge, skin, and the practice. And the guideline have been developed, but there is adherence is very low and often influenced by the personal opinion. And there was a paper published in 2018 which shows that there are few clinicians which are directly involved in the diabetic foot care, and the healthcare professional knowledge in this field is very poor. And so Tolle in 2009 has said that the world lack of recognized podiatry facilities, and only 19 countries around the globe having this podiatry services. And there are many other things as well, like lack of patient education and the availability of the dedicated facilities. There are some hospitals who do not have even the diabetic foot care services at all. So there are many gaps in the knowledge, skin, and the practice. And also, there is a delay in the referral, which lead to a high amputation rate. And I am talking about this delay, which was reported in 1991. And we are talking about now in 2023, and there was a paper still 30 years later, a paper published that was also talking about a delay in referral of the patient with a diabetic foot ulcer across the Europe. So we are still having problems in the referral system as well, which is one of the important aspect of the high amputation rate. So, my dear friends, the fast track pathway, which is a, a work of the International Diabetic Foot Care Group and the D-Food International, has developed an easy tool to use to support the primary health professional in the prompt referral and treatment of patients with a diabetic foot ulcer. And this fast track pathway is reflecting the recent international working group for the diabetic foot guidance and direct treatment based on the severity of the patient ulcer and the comorbidities. And this is one of the algorithm of this pathway, which most of the region has developed their own algorithm, and the country can make some changes according to the evidence in this as well. So this saying that you need to have a holistic approach towards the patient, the comorbidities need to be seen, and the patient divided into a non-complicated diabetic foot ulcer with a SIN-BODY score of 0 to 2, a complicated diabetic foot ulcer with a SIN-BODY score of 4 to 5, and a severe complicated diabetic foot ulcer with a SIN-BOD score of 6 with a severe infection. And then a referral has need to be based, and a standard of care is applied, and a stated a referral program is made according to that. So this program, the fast track program, is a pilot project, was launched in Pakistan last year. And the aim was to reduce the avoidable amputation across the Pakistan. And our objective was the provision of evidence-based standard of diabetic foot care to people with diabetes within or closer to their own vicinity. It means that their local physician or general practitioner who are doing the practice at their local area should be trained over there, so that the patient can get the foot care close to their vicinity. So it looks very simple that we took, and it looks that we took this pathway from the D-Food International, and then go and implement. By my dear friends and colleagues, this way, this pathway is not so simple to implement, and we took this project concept and made some changes according to our environment. Like one, we added a mildly complicated diabetic foot ulcer with the non-complicated as the mild infection. In this we put which can be treated by the primary healthcare physician, as we think, and there is more infection which is seen by the primary care level, and if left untreated by the primary care physician, then the infection can be worse. And then we train the physician who are the non-surgical physician and their assistant to diabetic foot care. And then we develop the mobile app for data collection, and then make a referral system between the primary care, a secondary care, and a tertiary care, and then to employ all of this to achieve a standard of care in people with diabetes who are having a foot problems. And so we now in Pakistan have trained about 113 foot care teams in 113 foot clinics in different provinces, 4 provinces of Pakistan, 81 primary care center where the diabetic foot care team has been trained, the 24 in the secondary care center, and the 8 tertiary care center where the diabetic foot care physician, non-surgical physician trained, and their assistant and trained into the diabetic foot care. We have planned the lectures and the hands-on workshops on them and train to the diabetic foot how to. And then make a connection between the primary health to the secondary and from the secondary to the tertiary, and then we make a referral back system as well, so that the patient can, if patient referred from a primary to the secondary and if it's got better for there, and then this patient can refer back to a primary care health physician. So these are the outcome from the September 2022 to May 2023. A total number of 542 patients were enrolled in this system, and about 42% patients were completely healed. 14% had a minor amputation. 1.8% had a major amputation. 11% were under treatment, and 12% were left against medical advice. 16% having lost to follow-up, and about 1.5% having death due to cardiovascular problems. And in terms of healing, you can see by this graph that the people who referred to the secondary or tertiary care system are having a good healing time. In terms of the healing time, they're doing better than who presented late to the secondary or the tertiary care system. And this is the healing times, which is significantly different in the three categories. So we have some barrier and limitations, and we have some solution for that. One of the barrier was the internet connection was not everywhere. Where in Pakistan and the city is available, but in the far-flung areas or the villages, it is not possible to have to use the mobile app. So this solution was provided, a simplified performer to collect the data and send us onto the WhatsApps. And this was the data collection performer instead of using onto the mobile app. And then the physician mostly said they had a busy OPD, that they just cannot the fill out of this performer, or they use the mobile app for that one. And then we try to provide some help to the assistant, and so that the solution was made. So my dear friends and colleagues, at the end, this fast track program of the DFoot International supports the primary care clinician who should provide the first intervention and the primary care professional plan and early referral to the specialist care in accordance with the severity of the individual cases. And moving ahead, we are launching this project. So we need helps from different association, corporate partners, ministries, the NGOs, the welfares, the institute, and the university to cut down the rate of amputation, to avoid the preventable amputation, not only in Pakistan, but I think this program can be launched in the MENA region as well. And what we are expecting, the outcome and expectation, we can reduce the healing time, we can improve the quality of life, we can increase the rate of limb salvages, and we can decrease the mortality due to the diabetic foot. And so we can help our patient in this regard, my dear friends and colleagues, by using this fast track program. So at the end, the time for action is now. It's never too late to do something. Thank you very much for your patient listening.
Thank you, Dr. Zahid, for an excellent presentation, as usual. I will leave the question till the end because we are lacking behind with time. And we will go to Dr. Abdul Razzaq Abdul Aziz from Syria. Hello, Dr.
Yes.
Hello. Dr. Abdul Razzaq, you are ready?
Yes, I am ready.
Dr. Abdul Razzaq will be talking about quality improvement in podology. Dr. Abdul Razzaq, the floor is yours. You can start.
Yes. Hello? How are you all?
Yes, it's working.
We'll talk about offloading and diabetic food management, quality improvement in offloading the diabetic food. After cost material. Diminution of load generally understood as relieving pressure from an ulcerated and through this term should more correctly be used to describe the reduction, redistribution, or removal of detrimental forces applied to the food. This forces may be major contribution factor to ulcer occurrence, relapse, chronicity, or deterioration. It is not always possible to remove all forces applied to the food. The clinician must think in terms of reducing the deterioration velocity, magnitude, and direction of forces or its redistribution. The margins of defeat and tiny bony prominences are already under a high degree of intrinsic pressure. Flooding is one of the cornerstones of successful diabetic food ulceration management and prevention. More type of loading. That's methods. It is a female acetate outsole, but the outer surface of the bandage, it is of a female and female acetate monomer closed cell of foam is type of foam in which the cells are closed and tightly pressed together with higher density and greater pressure resistance. After the dressing the bandage, even installed as an irreversible loading method. This insole is needed to fit every patient case. We used by beams and adhesive threads reported in every dressing changing. Reusable outsole. This our dressing. How we make the dressing, body dressing. That's one of the tests, how we on the head of metatarsal first. A 68-year-old female with severe infection in the hallux after wrong treatment of plantar callus treated with transproximal phalange amputation and plantar insole. This is the situation, this our overloading, our 65-year-old male with wet gangrene in first toe and midfoot, treated with amputation at the base of the first metatarsus, the plan for offloading insole and middle stabilizing of ankle movement by another piece of EVA insole. That's another piece to fixation the ankle. In parental tissue after severe infection and surgical debridement, anterior fixation of the ankle joint with parental fixation position. Wide debridement for gangrene on the anterior surface. It's still under treatment, but we make anterior fixation to make the patient need to work and make a problem in the parental. 46-year-old was a recurrent parental aspect of the head of first metatarsal ulcer, debridement, and offloading insole. You can see the fit of the body corresponding to the lesion. Top 77 on chronic ulcer since 5 months, debridement and offloading plantar navigated insole to avoiding with during foot and redistribution it to midfoot and forefoot. Cases 56 young-old female with Charcot osteopathy and collapse in natural common with grievances and plantar ulcer, modified plantar insole to avoid the pressure at bony prominences at ulcer site. This attention will in the Netherlands, talk about our measures. I asked him how he was talk about yes, depression, overloading, and mobility is one of extreme conditions with limited resources. This situation of when I talk about our low-cost material and our prices, data food American 2022. Thank you for Dr. Jamil.
Okay. Thank you, Dr. Abdul Razzaq, for your talk and for the offloading effort that you are doing. Thank you, Dr. Salma. Thank you, Dr. Bashir, Dr. Zahid, Dr. Abdul Razzaq, and also big thank you for Dr. Makki, who joined us and remained silent, did not disturb because he was the first speaker. Thank you, Ali Edifut. Thank you, our president, Dr. Abbas. And we hope that the diabetic population throughout the globe will improve and benefit from better health. Till we meet next year, kindly accept the best wishes from Lebanon, from the MENA region, and we hope that peace will prevail in Palestine. Thank you.
Thank you. Thank you, everyone. Thank you, Jamil.
Thank you. Goodbye.
Goodbye.